Good afternoon, everyone. This is American Surgery Center. My name is Kemal Erkan. It's our Bariatric Friday. I have Dr. Isaias Irgau with me. Dr. Irgau, how are you doing?
Kemal, I'm doing great. It's great to be back on Bariatric Friday. I do think we had a break, right, last week?
We did. Actually, 2 weeks, right? 2 weeks now?
2 weeks, yeah, okay. Yeah. So, yeah, it's great to be back.
Well, I do miss these events, so it's fun. Now we have 3 patients in this cycle, and most people are already familiar with them. But today we are going to discuss one of the important issue of why patients do drop out from the bariatric program once they start. Now, why this is important is because we have only 1% of the patients who are eligible for the bariatric surgery are going through bariatric surgery. Bariatric surgery is the most effective treatment for morbid obesity, yet it's difficult to get people there and then follow through and make sure that they stay. And from the patient perspective, because we do our daily case conferences, I have a really good understanding of why it may be frustrating at some point and then why they would lose the hope. And then this is also why this program is extremely important for our people, our patients who are dealing with morbid obesity issue. So, Dr. Irgau, you see these patients every day, and they are your patients, are other surgeons' patients. They have you directly see what they are struggling, and what can we tell the others who are in the program and how we can actually help them. So why do they drop out of the program?
Absolutely. So it is an extremely important topic, as you said, because to begin with, we see many obstacles to bariatric surgery, right? As you mentioned, only about 1% of patients who are actually eligible for bariatric surgery end up having bariatric surgery. And for somebody who looks at bariatric surgery as an option that may or may not be needed, that 1% may be okay. So it's a big deal, right? But we know bariatric surgery is dealing with a disease that is potentially fatal, a disease that is potentially going to determine how long a person is going to live, right? We have talked many times that the leading causes of mortality in our country are cardiovascular diseases like heart disease, high blood pressure, stroke, metabolic conditions like type 2 diabetes, right? Cancers. And guess what? Morbid obesity is actually an underlying factor in all these diseases. In other words, if a person has morbid obesity, they are very likely to develop this condition as well, which means they are very likely to die earlier than their life expectancy, right? Compared to the general population. And right now, as you mentioned, bariatric surgery is the most effective treatment we have. We're talking about morbid obesity, which is defined as a condition where the weight of the person is at least 100 pounds higher than their ideal body weight. We're talking about a body mass index greater than 35, greater than 40, right? So extreme levels of obesity, but unfortunately, a very, very common problem in our society, and increasingly so, right? So when we have such condition that is life-threatening, and we have a treatment that is so effective, why aren't many patients coming forward? Obviously, there are going to be obstacles there, right? And then, why are we not operating on them immediately after we see them? Why do we have to put them through the program? That's by itself almost like a contradiction, right? Come on, we're saying it's a very effective treatment. It's very important. Few patients are showing up to begin with. Why put them through the program that takes 2 months, that takes 3 months, and sometimes even longer, where the chances of them not continuing are actually going to be higher as well, right? Well, the reason is because the treatment itself, the surgery itself, is only one part of the intervention. Patients need to be evaluated. Patients need to be educated about many issues that are so important for their long-term success. And that takes time. That takes a lot of appointments. And unfortunately, when you put that with the real life that all of us live, it's not surprising that patients will not continue this completely, or not all patients will continue. And it's the responsibility of programs like us, by bringing this issue to the forefront, or by working within the programs in a way that as many patients actually stay with the program and continue. And I'm obviously very proud to say, Kemal, that because of the work we do, we have one of the highest completion rates of any program around the country, right? The dropout rate in our program is much lower than most of the programs around because of the effort we put. But nonetheless, there is a dropout issue. And the question is, what more can we do or to understand this and to diminish the number of patients that we lose through the preparation of the program?
So, we cover these things in like every 3-4 months. And as I'm listening, I'm thinking that patient who may already diagnosed for the heart failure, and then they have to go through the heart surgery, what's the dropout ratio of that? So then I'm like, okay, so well, it's probably not really high, right? Why? Because they take it seriously. So then do you think they are not maybe taking this seriously?
Well, that is an interesting viewpoint, Kemal. But let's look at it from another perspective, okay? Let's look at how the world around them looks at bariatric surgery, okay? So let's imagine you have a person with heart failure, okay? They tell their family, I have heart failure. Everybody's going to rush to support them. And they're going to say, when is your appointment? Do you need a ride to go to your appointment?
Mm-hmm.
Do you need help to go to this place, right? Because everybody understands the urgency of that, right? And they want to help. On the other hand, if you're going to have this conversation and say, hey, my doctor told me that I need bariatric surgery, people who may not be familiar are going to say, really? Really? Why can you not do it by yourself? You need to lose weight. You just need to eat less. You need to exercise, as if it was that easy. But that's the most common response people will give, because there is this underlying bias against obesity, as if it is a problem of appearance, as if a problem of lifestyle, right? So not only we have obviously society which is really biased against obesity in this sense, but also health professionals themselves have taken a long time before they really reach the conclusion that obesity is really a disease, Kemal, that has to be taken care of like any other diseases. So when you have this kind of bias, it is very easy for patients also to get lost in that situation and to start questioning themselves also, right? So education, strong education towards our patients we are doing, and we need to continue doing, but also sessions like this that should be reaching the general population, the community at large, is important, because we don't want only our patients to understand the severity of the problem and take the measures that we are recommending, but we want their loved ones, the community at large, to take obesity very seriously, right? As serious as other diseases like cancer or heart failure or others that are just as life-threatening as obesity.
Well, I think that's kind of like where the issue is, Dr. Erkan. So the understanding of morbid obesity is still lacking.
Yeah.
So
Absolutely.
one lacking is because the stigma, and then trying to kind of, we did have one patient dropped out last week. Immediately I look at her BMI. Well, I think it was 47.
Mm-hmm.
Now, when I'm around like 29 BMI, sometimes I go up and down. 29, I hope I never hit 30, but let's say 29, it's not comfortable for me. So just so that put it in perspective, that 47 BMI is a really high BMI. Yeah. There is a very, very, very slim chance that patient may lose that overweight on their own. I mean, we're not saying impossible, but it's next to impossible. So, and because the reason I'm saying is because she says, well, I'm going to try this on my own. And all I'm thinking is that, well, you are just going to come back with 30 extra pounds in 6, 7, 8 months, right? So it's not understood as disease is probably one of the other main issue. Before we go to the personal feelings of it, I think one of the big issue that I also see is the insurance process, like how the like right now for Medicaid, and this is something that I'm going to probably start working on it maybe more structurally with you, with our state officials. Why do you need 6 consecutive nutrition visits to qualify for this surgery if commercial patient is able to get this with three visits and it's not consecutive? So it's like I can have one this week and then 2 weeks from now and then 2 weeks from now, and I still need like a couple of months to go through the process. But why do you need to delay this? Because these are the most vulnerable people, right? So Medicaid, when we say Medicaid, that's 30% of the population in Delaware. And that's about 30% of our payer mix. So this group is already dealing with poverty. They are already dealing with the social determinant of health, elements of social determinant of health, the food insecurity, housing, economic issues, the education issues. So already a troubled population, we are putting more kind of like, we are making it more difficult for this group just because someone made these rules before. So that's I think one of the big reasons that we have, because like if I'm gonna get something, let's just start with me, right? So if I were to get this surgery now, I decided, and then I come to your office. Well, so I look at it, I can see the end of the tunnel if I'm a Medicaid patient, because I'm going to make those appointments now. We have telemedicine and all that. Like we are maybe it's a little bit more convenient than before, but if I have to come to your office, I need to find the right transportation. If I have some job because if I'm on Medicaid, I'm assuming that I'm not making enough money, therefore I'm not. I don't have access to certain means, so I may not be able to take time off and come to this appointment. And then now you're going to get a call from a care coordinator saying that, oh, so you're going to restart the process because you missed your nutrition visit. So this can make it where if I don't see the end, and it's not a reasonable time, so I can see this being a big hurdle for patients. And maybe this is something that we can actually try and put a little bit more pressure on the state officials, honestly, because this needs to be fixed. At least in Delaware, this shouldn't be the case.
Absolutely, absolutely. So clearly, patients need a certain amount of interaction with the different specialists to prepare for bariatric surgery. There is no question about that. Yeah. And we have a program set up to do that. Patients will need nutritional classes, patients will need psychological evaluation, patients will need to see a cardiologist, maybe a pulmonologist, sometimes another specialist as well. They need to have endoscopy. But you do not need 6 months to do this, right? You do not have 6 nutritional classes that have to be 1 month apart, where you're not allowed to miss 1 month. Otherwise, you're going to restart the whole process. Well, when you put it that way, it looks as if you are making the patients earn the right to have bariatric surgery, right? It looks like airline mileage, where you have to do this many mileage before you can have this upgrade, because before you can use your mileage to do that, right? Instead of looking at a person with a disease where you are trying to help them get through as effectively and efficiently possible through the needed preparation and then have the surgery, right? But instead, it looks as if many of the people who are putting these regulations are trying to make sure that patients earn the right to passage. In other words, you have to fulfill XYZ and show us that you can do XYZ before we can give you this life-saving treatment. That's a wrong approach totally, right? Instead of encouraging people and say, you need the preparation. And this is what we're going to do to make it easier for you to go through the preparation. Right? If you have to put your life upside down to be able to go through the preparation, and if you're already facing huge obstacles when you are approaching the subject itself because of the bias of publicity, it's no wonder that patients are dropping off, right? So you have to say to yourself, what is the real goal of the people putting these rules that they have to be 6 months? Are they trying to encourage patients, or are they trying to put hurdles in front of them so that they don't go through the surgery? Yeah, it's a very cynical viewpoint, but you are not really totally wrong to question these things, Kemal, because it does not make any sense, as you say, right? So what we need is we need more awareness, not at the level of our community, so our patients are more aware, not on the level of our doctors, so they really start these discussions when they see the patients, but also at the level of the legislators and other people who have decision-making authority on all these issues that affect us. And I'm glad really that you, Kemal, are able to approach these things when you have discussions with our legislators and others, because you really are advocating for our community, and that's what we need also. And we have to do this even more proactively. So when we look at the dropout rate, you could focus on the patient and say, well, they didn't come here, they didn't come there, or you can look at the bigger picture and say, are we facilitating the process, or are we putting hurdles? And if we are putting hurdles, what we can do to get these hurdles out? Right? So our most important concern should be the fact that the vast majority of patients who suffer from morbid obesity are not coming forward. Our most biggest concern should not be the fact that patients are coming for bariatric surgery. We should encourage that. Even for any insurance plan, hands down, their long-term expenses on those patients are going to be much lower if they invest on bariatric surgery, as opposed to continuing to treat diabetes, high blood pressure, heart failure for and on. You know, why the patient suffers.
So just kind of like maybe regroup on this, so then I don't want to confuse people who are watching this. So it's 6 months is only for Medicaid. So if I have Blue Cross, Cigna, I think Cigna is still requiring 6 months without the consecutive 6 consecutive visits.
Yeah.
But Aetna is okay, Blue Cross is okay, and I think United Health is okay. Now, what we do for those patients is different in a way that since there's no consecutiveness, then it's not like punitive punishment of, oh, you failed something, you're out. So why this is important for this group is because these patients who are dealing with morbid obesity are also dealing with other chronic illnesses, but one of the main one is the depression, anxiety, right? So because this comes with self-esteem, how happy you are with yourself. I mean, we don't have people. I mean, I was watching something earlier for the earlier episode for the United Medical event. This is happening in one of the cable shows. The guys, the FTX guy, the crypto money, the one who. My son was telling me about it. Yeah. So that guy, they were making fun of his weight, and then this TV host was saying that he should put a bra on because he was overweight. Okay. So his boobs were kind of out, and I mean he's a bad guy. We are not saying that we are not defending him, but we are looking at it from the him being as a person, human being. So if he had like if he had stroke, were we going to make fun of his stroke just because he left the country with 15 billion? No, right? So, but this is an easy target. So we said, oh, well, he have a lot of money. Why is he fat? That's what this guy said, pretty much. I know we are not allowed to use the F word. So, but this is exactly what, and that bothered me. Like, even though I'm upset with this person. So Bitcoin is down to 4,000. I had I put it as 8,000 total. So, but my clinical approach immediately from the training that I got from our system here is, well, this is a person. We can't say that. I can't tell the guy to put a bra on, because this is a problem that he's dealing with. It doesn't matter what he did, what he's gonna do later on, but his chronic illness is a chronic illness. So that's, I think, one of the big problems. I think this depression is also affecting patients' process, so they're not able to see results quickly. So then they're not able to stay with the program, right? So one thing that Dr. Ergau, I think you're going to like this. And these events are also kind of our brainstorming. So why is it? Because we are actually processing this, and then sometimes because we want to be a little bit more creative, we also try to put a different perspective every time. And you know that I sometimes fail with this, but usually it works. But one thing that I'm thinking is that maybe insurances came up with this for Medicaid is because they didn't have American Surgery Center program in place. Now, you are the face of bariatric surgery in the last 22 years in Delaware. And I've been with you since 2003. And then actively running the practice since 2012, and actively running the surgery center since 2015. And part of what we used to do is we used to have these old programs. We were part of the hospital systems. And remember, I used to get in trouble for asking more frequent case conferences. And I was the only non-physician in the room. And I have all the physicians, psychiatrists, and other clinical people. And I would tell them, well, this is more, it should be done more frequently. It's because patients are dropping. We have to be able to better handle them. So then we find a different way. We said, look, our program is, it's going to be this way. This way is daily case conferences with nurses, not some, office admin staff. It's a nurse who's reporting back to the people who know the bariatric surgery the most. And maybe insurance, if we approach them this way, then perhaps we can make a change on Medicaid. So because I called, like today in the case conference, so I can tell you, so I called 2 patients. And the reason I called, like normally, that I don't call them necessarily because our people are calling, but the reason I had to call is because this week actually it happened 3 times already. It's because patient was kind of like Medicaid patients, they were about to drop. We were about to close the case. So here, 1042, and then 1012, and then the day before. So is because we are not just holding hands, we are holding them so tight. So if we make that point, maybe we can make a better impact on this discussion. And I'm hoping that maybe we can actually take it to a different level for this very specialized program that we have in place. Because our patient dropout ratio is half of the industry dropout ratio.
Yeah. It is.
So that's because we keep them engaged.
Yeah.
So it's so easy to just kind of say, oh, you know what, you missed 2. We are not going to be, it's too bad it's the last week of November, so we don't have enough time. No, we don't do that.
Yeah.
We go out of our way to make sure that we keep those people in place. So now, I don't want to miss other points, Dr. Ergau. Do we have other reasons for the dropout?
No, I think, clearly, obviously, there are going to be situations in which people, things happen in their life and they have to postpone this, they cannot go away, and we understand that. And also, it is very, very understandable when patients do not feel ready to proceed with the surgery. And I have this conversation with patients very often. I tell them that the typical bariatric patient who goes through the process is somebody who has thought about bariatric surgery for at least 2 years before coming to terms with the idea that they need bariatric surgery. And the reason for that is because they need to be comfortable with the changes that happen, right? And at the beginning, they may not be, and it's absolutely fine. And that's the discussion also occurs at the beginning when I tell them that, look, you going through the process does not commit you to the surgery, right? It is a process of discovery, of education, of understanding, on looking at the options. And that's exactly what it is also, Kemal, right? But obviously, in that process, it's okay for patients to say, look, you know what? Give me some more time. I want to work with the way the nutritionist has told me. I never even knew that you could do these adjustments and these changes. Let me try that. And it's okay. We're not saying that bariatric surgery is a question of emergency here. What we're saying is it's something that should be on the options that we offer patients as a very, very legitimate treatment, but also as the most effective that we have currently available, right? You talk to many patients and you ask them what's their biggest regret after bariatric surgery. And the most common answer is that they regret not having done this years before, Kemal. That's what they tell you, right? Meaning that they have suffered through the ravages of obesity needlessly for so many years when they could have had bariatric surgery a lot earlier, right? But people need to come to that realization by themselves. They need to understand that this is not something that we can prescribe, right? And it's okay. So there are patients who, want to hold off, and that's okay. What we want to do with this discussion is we want to eliminate the hurdles that are unnecessary, that are discouraging people from pursuing this important treatment. And that includes really eliminating unnecessary, lengthy processes that are put there really almost as if patients have to earn the right to passage, as I said, when there should never be anything like that. If a patient has an illness, you don't put the treatment in front of them as if it was a carrot and say, hey, you have to do X, Y, Z for me to give you treatment. That's totally unethical, right?
So I think the separation of process to get them ready, prepare them, versus making a process that's long enough so we'll see if they're going to actually really finish.
Yeah.
That's the punitive way that I always use that. Absolutely. So like if the down in 13 in Sussex County, the small towns, they don't have enough income, so the police waits right literally next to the speed limit sign, right next to that, and it goes from 65 to 35 or 55 to 35 with no warning, and then he's right there. So then you get your ticket, so because they need income. That's a punitive way of dealing with the issue, right? So what we are saying is that there is a process, there is a program, because we won't, even if you are a self-pay, you won't get a surgery next day or next week or next month. You are going to go through the proper clearances, which takes about anywhere from 8 to 12 weeks without too much pushing. Yeah. And that's a reasonable time where you are going to be busy with a lot of stuff anyway. So, but once it's over 3 months, then we are in trouble. We lose people. Yeah. So, from Dr. As you are the president of the local chapter of ASMBS, perhaps this may be one of our, 2023 New Year resolution to reduce the Medicaid down to 3 months, and we can make impact on more people's lives.
I like that.
But this is, again, like we keep saying, this is I'm not going to say it's the only, but this is the most effective way of fighting morbid obesity. This is the solution. So then if the solution is used the least, then you know that you are not going to get to the resolution. So that's what we are trying to do here with the society that we live in. Morbid obesity itself is one of the biggest issue that our community is struggling with. So when we covered we had our lieutenant governor in one of the earlier events, and we went up from 34 to 7 on ranking of the most or morbid obesity or obesity in the United States as the state of Delaware. I think child obesity, we are number 3. So this is something that's going to be out of control. It's affecting people in so many different ways. Like, I see from the accountable care organization side, with our clinical integration approach, like when they're trying to, treat diabetes, hypertension, and some heart problems, there's morbid obesity, the big pink elephant sitting in the room, and no one is, patient is okay. Sometimes providers are okay. Well, that's what we are trying to break here, so then we can actually help the dropout rate. And I think from United Medical ACO side, Dr. Ergau, as you are the chairman of the ACO, we make an impact. I see that. So the behavior is changing, and the changing behavior is a slow process. So, but I think that is happening. So that's the green light that I see. It's a slow process, but process is still important in this. We see good progress. And I think in the next couple of years, when we look back, it's going to look a lot different than what it is today. The future is bright. Yep. So hopefully we can help more patients again. So we are here available for our patients. And as the bariatric team, bariatric program, our goal is to make an impact in your life. So hopefully we can help more people. So we'll be back next week.
Absolutely.
No, I'm lying. We won't be back next week because it's the day after Thanksgiving. So although we may end up doing this, I don't know what your schedule is, Dr. Ergau, but anyhow, so we'll be back.
I'm always good for Bariatric Friday, Kemal.
We'll be back after. Now this Tuesday, we have Dr. Ibrahim. If anyone is interested in the actual full process of the bariatric webinar, Tuesday, 6 p.m., I believe.
Yep.
The Zoom link should be available at CHRIAS website. So you can always register and then attend that. That's a little bit more than an hour. And that's more interactive with patients who may be already interested in, didn't have an appointment. So feel free to join us. Well, Dr. Ergau, always it's a pleasure to have you, and it's a lot of fun, a lot of learning. So thank you.
Thank you, Kemal. Thank you. Good night, everybody. Thank you.